Hello, everyone. My name is Christian Mershon. I'm the Assistant Director of Clinical Pharmacy at NYU Langone Hospital for Crit Care, Emergency, and Perioperative Services. Today, we'll be discussing advancing sepsis detection in the ICU, assessing the utilization and benefits of T2 Candida. For candidemia, it accounts for nearly 70% of invasive fungal infections, with Candida albicans being the most commonly identified species. However, the prevalence of non-albican Candida species varies geographically, and the most common non-albican species differ by region. For instance, in the United States, Candida glabrata is the second most prevalent species, while Candida parapsilosis is the more common species in South America, Southern Europe, India, and Pakistan. Now, prompt diagnosis of candidemia is critical to reduce mortality. Delays in treatment can significantly impact outcomes, with mortality rates in septic shock cases rising up to 90% if treatment is delayed by more than 24 hours. So, the fear of delayed treatment often leads physicians to empirically overuse antifungals even when the prevalence of fungal infections is low. And we can see here in a 1-day international ICU study, over 7.5% of patients received antifungals without positive evidence for invasive candidiasis. Now, for conventional blood cultures, they have limitations that drive the overuse of our antifungals. Now, the reason for that is that sensitivity is relatively low at 65%. The turnaround time can extend up to 3 days or longer, and prior antifungal use may result in false negative cultures based on limited yield. And in the setting of polymicrobial infections, one pathogen may outgrow another, potentially masking the presence of Candida and delaying appropriate therapy. Strategies have been developed to address these challenges, and these strategies include preemptive treatment, triggered by non-culture based evidence such as colonization or fungal biomarkers like beta-D-glucan or T2 Candida, empiric treatment triggered by clinical signs of infection or including a fever and probably overuse of antibiotics, and probabilistic treatment based on risk score assessments or clinical rules. So, given the limitations of blood cultures, we will explore the role of advanced diagnostics, focusing on the use of beta-D-glucan and T2 Candida. However, how do we come to choose the right test? It's going to be based on a couple characteristics. We want our test to be readily accessible, have a quick turnaround time, be accurate and reliable in order to facilitate decision making in a timely fashion, which would ultimately improve patient outcomes and be cost effective. The following table represents the two things that we will be evaluating today, which include beta-D-glucan and T2 Candida. We'll address beta-D-glucan first on your left-hand side. And what is beta-D-glucan? Well, it's a pan-fungal marker in the cell wall of fungi. It's a serum-based test that looks at colorimetric assays, and it targets a broad range of fungi that includes Candida. With the prevalence of invasive candidiasis at 5%, the sensitivity and specificity is around 80%, with a positive predictive value of 17% and a negative predictive value of 98.7. Now, on your right-hand side, we'll look at T2 Candida. It measures Candida species DNA in whole blood. It's a molecular diagnostic test that uses magnetic resonance technology that amplifies your rRNA sequences. Now, it targets 5 Candida species, which includes albicans, tropicalis, glabrata, crucei, and paracillosis. And with the same prevalence of invasive candidiasis, the sensitivity is at 91%, the specificity at 99.4%, with a higher positive predictive value than in comparison to beta-glucan at 71.6%, and a higher negative predictive value at 99.5%. Therefore, what are some of the considerations we'll actually use beta-glucan? Well, in comparison to previous data where you used risk prediction models, colonization index, and trying to predict a blood culture negative invasive candidiasis, beta-glucan works extremely well, and that specificity can be enhanced by using higher cutoff values such as 200 as compared to the 800 picogram per ml produced by the manufacturer, or by requiring 2 consecutive positive results with a moderate decrease in your sensitivity. So when looking at the types of infections, bloodstream infections are not the global use for beta-glucan. We wouldn't recommend it. We would use routine blood cultures and T2 Candida to guide our antifungal management. For non-bloodstream infections, this is where beta-glucan can exist and has a place in therapy. But it comes with a couple caveats. You want to make sure the patient has a deep focus of infection, routine cultures are unavailable, you can't get them, and at least one of the following, right? They need to have an abdominal source, any suspicion for infected necrotizing pancreatitis, or a known recent candidemia where there's a suspicion of a deep-seated focus. The disadvantages of beta-glucan are multifaceted. We'll look at sensitivity variability, where the sensitivity per fungal organism actually is variable, and the lowest sensitivity with Candida parapsilosis. Now, this sensitivity cannot distinguish between past and acute infections, so that's something to keep in mind. Now, it's also non-genus specific, which requires additional tests to kind of identify what fungal organism you're dealing with. The positive predictive value and its interpretation, because it's so low, it can lead to antifungal overuse if the tests are done inappropriately or sent inappropriately in patients who have a low risk for invasive candidiasis. And this is mainly stemmed from the test results can yield false positives. So therefore, clinical context is crucial for interpretation. For instance, if we look at our transplant population who do receive IVIG to a certain extent, IVIG therapy within 3 weeks will give you a positive beta-glucan despite the patient not having any invasive candidiasis. Blood transfusions, blood-derived products such as albumin, surgical gauze with cellulose and glucans, and renal replacement therapies with cellulose membranes also contribute to a false positive result. Now we'll discuss T2 Candida and go through its pros and cons. So on the left-hand side, we'll go through the pros first. It's designed to detect only intact Candida cells and not circulating DNA. Its detection of Candida within 3 to 5 hours. Unlike other platforms, it does not require positive blood culture before identification of Candida, and it's not suppressed by the presence of antifungal agents. So you can give your antifungal agents and then get the T2, and it shouldn't disrupt the findings. And it has a low level of detection of 1 to 3 CFUs per ml. So what are some of the cons? Well, the cons are limited, and here are some of them. Only detects 5 Candida species, but these 5 Candida species accounts for greater than 90% of invasive candidiasis. Now, one thing to note is that it won't pick up Candida auris, which is on the rise in most of our ICUs. The sensitivity of 91 and specificity of 99.4% for candidemia is high, but it has a poor sensitivity for detecting those deeper seated candidiasis without candidemia. And clinicians are forced to rely on historical susceptibility patterns as resistant mechanisms. This comes into play where you will get a positive T Candida result, such as a discovery of a positive Candida glabrata. And based on that finding, you would determine that mycophenolate or any acetocandin would be the drug of choice in that setting, as there's variable dose susceptibilities with fluconazole. To address some of the discordant results we see between a positive T2 Candida and a blood culture that may not be positive, but it will be negative still to date, there are some contributing factors that we'll address. Well, T2 Candida has lower limits of detection than blood cultures. We said that before. The limit of detection is as low as 1 CFU per ml. Suboptimal number of blood cultures also reduces the sensitivities of the blood culture assessed. So one blood culture has a sensitivity of about 65%. You send off multiple, that increases the sensitivity to 90 to 95%. But you only have to send off one T2 Candida. For low blood volume collections, it also impairs your blood culture results because the optimal volume is about 10 mLs for an aerobic bottle. And prior exposure to antifungal therapy will also affect the yield on your blood culture results, where it doesn't do that to T2 Candida. Now we'll go through the utilization of beta-glucan and T2 Candida in candidemia testing that we conducted at NYU. And we did this as a retrospective study at 2 NYU Langone Health Hospitals from 2017 to 2020. It included 216 patients, and we compared 2 diagnostic practices where practice 1 was a blood culture and a T2 Candida. Practice two was blood culture, T2 candida, and sending off a beta-glucan. We excluded anybody that had previous candidemia. For our positivity rate in practice one, based on just T2 candida, we saw that the positivity rate was 3.1%. And for practice two, it had a very high positivity rate of 24.2%. And what was driving this positivity rate? It wasn't invasive candidiasis, it was a positive beta D glucan, as these patients had this particular finding. Now, in terms of like outcomes of what we were trying to assess, we saw that antifungal discontinuation at day three, there was no difference between either practice. But what we did observe was that there was a decrease in overall antifungal utilization. And with practice one, which incorporated T2 candida and no beta D glucan, we saw that we used 40% less antifungals in comparison to practice two, which utilized the beta D glucan diagnostic strategy. And the antifungal duration was a lot shorter, not significantly, not statistically significant, in comparison to practice two. Therefore, there was no difference in new candidemia diagnosis using either strategy, so one is not superior to the other, but it did lead to differences in how clinicians interpreted it. So in patients with negative blood culture and T2 candida test, a positive beta-glucan result led to inconsistent clinical decisions, with only half completing antifungal therapy for candidemia. Now, if you increase that cutoff of beta-glucan, it went from 50% to maybe 75% completing antifungal therapy. But even then, we saw that it that beta-glucan test resulted in increased antifungal use without any clear benefit in its utilization. Now presents the patient case where we'll meet patient RD. This is a 58-year-old male, status post an emergency laparotomy for perforated diverticulitis. Postoperatively, he was mechanically intubated, requiring vasopressors and VA ECMO for hemodynamic support. His past medical history included diabetes, heart failure with reduced ejection fraction of 20%, COPD, OSA, and obesity, and his surgical history included a remote hernia repair. And we do have a Candida assessment checklist in which we'll go through some of these variables to identify the patient's risk for candidemia and whether we'll send a test or not. So RD's SICU course is he started on vancomycin and piperacillin tazobactam initially, and on post-op day 3, there was a clinical decompensation in which he became febrile with a Tmax of 39.2. He required rising vasopressor support for his blood pressure. His white count also increased from 18 to 28, and the transfusions, he was receiving 2-pack red blood cells and cryoprecipitate. For our Candida assessment checklist, we saw that this patient was not immunosuppressed and did not possess any Candida colonization sites. However, the patient is critically ill, in septic shock, has organ failure, and an abdominal source. Therefore, T2 Candida was sent with initial blood culture, still no growth to date, so we don't know if there's Candida present, but we'll send a T2 Candida, and micafungin was empirically started. As the T2 candida was sent, we identified that it was positive for Candida glabrata. The time to the result was 4 hours. The blood cultures still had no growth to date, and we continued micafungin for this utilization. Now, as we progressed through this patient's course, the blood cultures remained consistently negative. However, the T2 candida was positive, and this could be due to multiple variables, being that one, it was a translocation that could have possibly happened in that setting, or it was a lower level of detection that the T2 candida was able to pick up. All the while, with the T2 candida result being positive, we completed our 14-day regimen. Some of the key takeaways from this discussion is that one, the decision between beta-glucan and T2 candida. Choose T2 candida for rapid specific detection of candida species in blood, especially for suspected candidemia. Use of beta-glucan, you can use it for broader fungal detection, including non-candida species, but the focus is mainly on deep-seated infections that don't result in candidemia. The T2 candida offers rapid detection of candida species within 3 to 5 hours, which it improves timely diagnosis and appropriate management with your antifungal agents. And proper interpretation of your T2 Candida results in conjunction with clinical context and based on the prevalence of invasive candidiasis within your ICU is crucial for guiding antifungal management and improving patient outcomes within our ICU settings. That concludes my presentation. I'd be able to take any questions. Thank you.